Rick Duplantis, and this program is It's Your Health, a program designed to empower you with information and knowledge to make healthy choices to improve your health. The topic tonight's show is high blood pressure. My guest tonight is Dr. Eric Fontenot, internal medicine physician that's practicing here in Lafayette. His clinic is located in the All Center. Dr. Fontenot, I have a question. My first question on this topic of high blood pressure. Can you tell us what is high blood pressure?
High blood pressure, also known as hypertension or arterial hypertension. High blood pressure is caused by two things, and basically there's a volume component and there's an arterial wall component. And when the pressure is elevated beyond 120 millimeters of mercury, it is what we call arterial hypertension, which can, of course, lead to disease and health problems.
Can you explain the two numbers? There's a bottom number. People talk about the top number and the bottom number. You know, the systolic over the diastolic as we know it. And would you elaborate on that, kind of explain the systolic and diastolic numbers?
Sure. The top number represents the systolic pressure, which is basically a measure of the pressure of the blood ejected from the heart into the arteries or the arterial system. And the diastolic pressure is a measure of remaining pressure in the arteries once the aortic valve on the heart closes off its communication to the arterial system. The remaining pressure would be known as diastole or diastolic blood pressure.
You know, you have a patient that comes in for blood pressure. What is the workup for hypertension or high blood pressure?
The workup for hypertension begins with primary versus secondary causes, and but even before that, to properly diagnose high blood pressure, we need a specific reading on 3 different separate occasions to diagnose hypertension if it is clinically suspected. And what would make us suspect hypertension? These are based on genetics, family history, even body habitus, medications, general condition of the patient, things like that.
Right. And for us regarding hypertension, what is white coat hypertension? You know, you hear people saying, I've got white coat hypertension. It's put on a white coat and they get blood pressure goes up. Explain that to us. And I think that white coat is kind of a pre-hypertensive state for most individuals. They have white coat hypertension. But can you explain that terminology of white coat hypertension?
When a patient enters the physician's office or emergency department or whatever clinical scenario it may be, the patient may see the doctor's office and associate that with a white coat, creating anxiety. This anxiety, again, raises the systolic blood pressure a few points, possibly several points, which could give an actual false reading at that time, and which is why we require 3 separate readings on 3 separate occasions to make the diagnosis.
Regarding that, what intervention do you start with once a person has been diagnosed as hypertensive or high blood pressure? What number is the cutoff for high blood pressure, as far as the systolic over diastolic? What would it be?
By definition, anything with a systolic blood pressure greater than 120 would be considered hypertension. Now that breaks off into 2 separate causes and 2 separate categories. The first being, let's talk about causes, or rather, let's back up and talk about categories. There is basically essential hypertension, which is basically a triad of genetics, family history, and body habitus, as well as other lifestyle factors such as smoking, and things like that. Whereas secondary hypertension comes from other causes that we can control.
Yeah, that's what you're saying. And the different stages of hypertension as well, stage 1, stage 2, and stage 3.
Right, exactly. Stage 1 actually is defined by a number, systolic number and a diastolic number. That systolic number usually being from 120 to 139 is categorized as type 1 hypertension. Whereas 120 to 129 would be what we call prehypertension. And stage 2 would be considered anything from 140 to 160 would be considered secondary stage 2 hypertension.
Regarding, let's say I come into your office and on 3 different occasions I've got an elevated blood pressure of above 140/90.
Okay.
And thus this diagnosis, you make the diagnosis, I have hypertension. What is the standard of protocol to treat a patient for the first time with high blood pressure that has a diagnosis of high blood pressure and it's at that level?
That's a good question, Rick. Basically, that's when the physician needs to diagnose this hypertension as being primary versus secondary. And that's very important in a general approach to the treatment protocol.
Is there any lab work that's done at this point in time?
Well, first of all, with primary hypertension, again, we talked about genetic factors, body habitus, we talked about basically things that are out of our control, things that we are born with. Whereas secondary, these are reversible causes, potentially reversible causes of hypertension. So in the workup, we start again with a good history and physical examination.
Correct. Does the blood work have any, lab work have any place in the workup of a hypertensive individual?
Lab work generally comes at the end of the history and physical examination during the patient encounter. We generally start with a metabolic profile, basic versus complete. We generally prefer complete, and a complete blood count, which may assess for any residual damage of hypertension.
I would think potentially it may show some form of secondary hypertension if we can do some blood work. That might kind of bring that out. It might come out at that point in time if at some
Right.
points in time doing that type of blood work. Talk about the drug treatment for hypertension. What medications are used to treat, what class of medications, number one, and kind of give us a rundown of that, please.
There are different classes, but again, that's dependent on the end result of the diagnostic workup. When we draw these labs, we do them for a very good reason, and we look for a salt overload, we look for a sodium-potassium sort of ratio to determine if this is primary hyperaldosteronism. We also look for...
Those are secondary causes of hypertension, hyperaldosteronism and the pheochromocytoma
Right,
type
and
conditions,
that's basically going to determine the
and
treatment
that may
protocol.
come up in the lab work. For instance, you might see elevated BUN and creatinine. Index of the kidney may be some disarray there with that type of blood work. I was just curious about that with you.
Once we determine the cause, then it sort of branches out into that direction of workup. If it is a secondary cause, such as renal vascular hypertension, we would start with a renal ultrasound and possibly a renal scan to determine if this is caused by a defect in the kidneys or the vascular supply to the kidneys. And then if the cause is on the other end of the spectrum, such as metabolic, which is could be sodium overload or primary hyperaldosteronism, well, then the treatment could be surgical and not medical. It all depends on what this workup yields at the very end of the patient encounter, and once the workup is complete, that'll determine our treatment. And to get back to your question about the drugs we use for primary or what I would call essential hypertension, we generally will start with one drug if your systolic blood pressure runs anywhere from 121, say, to 139, 140. We'll start with monotherapy. Stage 2 hypertension, 139, in that range, say 130 to 150, 159, 160. And then combination therapy is indicated in stage 2 hypertension. You must start with 2 drugs to adequately control blood pressure.
Right. Let's kind of hark back to the point where you just have given a diagnosis of hypertension. The blood pressure is 140 over 90. And I say, Doc, I really don't want those drugs right now. Is there anything I can do besides taking medication? Because I've read about these side effects on the internet. A lot of patients are going to the internet now. It's like a medical library on the internet, and they're reading all this material. A lot of it's scary. They lack the background, of course, to really interpret this information. And you hear it all the time. I went to the internet. How about this drug or that drug that I could be on? But, person says, I don't want to start the drugs. Is there something I can do, Doc?
Absolutely. The odds of success of this aren't always gonna yield themselves, but the very first non-pharmacological treatment of essential hypertension is weight loss. It's weight loss across the board.
Correct.
And does this work? It works. For every pound you lose 3 points in systolic blood pressure. It's almost a mathematical formula.
Yeah, well, that's impressive. If you can lose weight, if you can drop 30 pounds, if you're obese, you have abdominal obesity, you drop 30 pounds, you cut yourself back, chances are you're not going to need the drugs. You may not have to go on medication.
Exactly.
And if you maintain that program, we live in South Louisiana. Everything is highly seasoned with a great deal of salt. And when we go out to a restaurant, we have great places to eat. We're fortunate here in Lafayette. When you go out to eat, there are 3 things in all our food that make it taste great. Salt is number 1 ingredient, and fat, and then sugar. All these things, of course, bring us to the obesity issue, the fat and the high sugar content of the food to make it taste great, and also the salt brings us back to the overload hypertensive situation where these people are taking in far too much sodium, and it causes an increase in the intravascular pressure because all this fluid, from that standpoint. But so we can address this from a lifestyle modification standpoint then. With these patients.
We sure can. With weight loss comes lifestyle changes, and these lifestyle changes will be decreased sodium intake, decreased total caloric intake from fats and from processed carbohydrates. And now actually behavior modification has come into the picture, especially in the treatment of the obese diabetic, where these lifestyle changes focus on behavioral changes such as don't sit down with the whole bag of chips. Pour some in a bowl, then sit down with your chips or crackers or whatever it may be. These behavioral changes can help just as much as drugs or other lifestyle modifications. And that's where the treatment is headed towards now, not just with the drugs used in hypertension, but the overall causes of hypertension.
So this would constitute somebody that maybe needed 2 drugs to control their hypertension, maybe just 1 if they did lifestyle modification. I mean, like you said, it may not be the answer to their particular problem. It may not get them where you need them to be on the scale of being, their blood pressure within normal ranges. And what is the goal that you aspire to when you treat a patient with hypertension that you want them to get to? It's safe.
When you're going to start dropping someone's blood pressure, if it's especially in the 160s, 170s, 180s, you're going to you're going to tone your therapy to that patient's clinical symptoms. You're not just going to treat numbers, you're also going to treat the patient. And what I mean by that, when you drop someone's blood pressure too rapidly, say they baseline 160, 170, which is stroke range, and you drop that blood pressure, they're going to feel differently. And they're really going to feel, so to speak, a bit weak, or they may feel some vertigo, some fatigue. Because
Because you're used to operating at a much higher level of blood pressure wise, they're going to have lack of energy
right.
when you bring them down. So I guess I would think you bring them down slowly so that it's not a dramatic drop in blood pressure to
Exactly.
minimize these symptoms. I guess.
Even though a systolic blood pressure of 160 on higher requires combination therapy, you still want to start with monotherapy when you start to drop the blood pressure. Then you come in with drug number 2, if need be, and pay attention to this patient's signs and symptoms and how they're tolerating these medicines, because all of these blood pressure medicines, which we're going to talk about in a few minutes, are going to have side effects, some of them quite significant.
While we're talking about lifestyle modification, and I brought up the evil one, sodium chloride, having this dynamic effect on blood pressure. Can you expound on that from that standpoint of what is an acceptable level of sodium intake daily that you want to achieve with that patient, so that they will not be having this volume overload from too much sodium, the kidney's inability to handle that excretion of sodium, causing that intravascular volume to go up, thus boosting their blood pressure up. Where do we draw the line as far as how much sodium can the patient take in?
The key, I can explain it in one word: moderation. And to give you a specific number, a 2-gram sodium diet daily at each meal is what's recommended, and has been recommended for years by the American Heart Association. Now, it's also going to depend on your medical profile, but a 2-gram sodium diet is the mainstay as far as for a recommended sodium intake.
Okay, good. And in that range, I've read in the literature as well, you can cut heart attack risk, stroke risk in half, or 50%, and that's dramatic. If you can bring down the sodium that much, and then, like I said, the individual, based on how high his hypertension is, it may not need the drugs. If he can stay on that diet, that's the key thing. And before we get into the drugs, when a patient's put on a drug, I'm hoping that they're getting good counseling from their physician, that this is not a pass. Take the drug and keep living your lifestyle, and this will bring down your blood pressure. I hope that the person realizes that, look, this is an aid to get you down to where you need to be now, and it takes a few weeks for the blood pressure medicine to kick and actually work, but to allow them to change their lifestyle to where they don't have to. Eventually, the idea is maybe hopefully get them off the medication. Your input, please.
Once you implement lifestyle modifications such as weight loss and exercise and diet, and you start them on a blood pressure medicine until these lifestyle modifications start to work. When the weight starts to come off, they can eventually come off the medication. This has to be monitored, and it's important for the patient to realize that semi-frequent visits will be necessary in order for the physician to make these changes, if necessary, come down on the dose of blood pressure medicine, or possibly even take one away or both away.
Well, I guess it gives you a chance to monitor it over a period of time, that the patient's being compliant with their lifestyle changes, they're keeping the weight down, the blood pressure's staying low, and then you ease off, maybe on the medication.
Yeah, and that brings up another very interesting point, compliance. Medical compliance. I cannot stress enough, especially to not only people with high blood pressure, but all people on medication, how important this is. And even as a tip to the public, just to show you how big of an issue this is, insurance companies are paying very close attention to your compliance. If you don't go refill your medicine, they're going to know about it, and it will affect your rates to come.
So there's a
And
checks and balance system in place now to make to motivate the patient to be compliant. with the
actually,
treatment.
there is.
That's good.
Pharmacies now have automated callbacks to remind you to fill your medicines, not just so the patient doesn't have an excuse, so to speak,
Yeah.
but it's
No.
to help in the overall compliance and general health of the patient and the entire population, and it sets a good example for compliance.
Let's talk about the drugs.
Let's talk about the drugs.
Okay. Talk about the class of drugs that you use to treat this hypertension, this high blood pressure.
Okay. Essential hypertension, starting with type 1 hypertension. Diuretics are the mainstay. Salt-losing diuretics tend to be more effective than some of your other diuretics that cause you to lose only free water. But diuretics, we'll just keep it simple. Diuretics are the mainstay. If diuretics are contraindicated for some other medical condition, then we tend to go into the next phase of other medicines such as ACE inhibitors or angiotensin blockers to treat the hypertension. And then we come in with a second drug of another class if combination therapy is indicated.
I understand. And it sounds like all these drugs are geared to affect the kidney. And of course, the kidney being the target organ, the autoregulation of our blood pressure in our body, actually these drugs all address that organ in different capacities. I want to talk about what I mentioned early on in my scenario that I didn't want to be on blood pressure medication because of all those side effects I read about on the internet. There are some side effects of the diuretics. And
Oh, yes.
let's talk about those. The glucose intolerance potential behind that, the low sodium, loss of potassium, because it's blocking sodium. That's how it controls the water reabsorption of the kidney. And also, go ahead and elaborate on that for me.
Okay, let's hit on low sodium with diuretics, which is diuretics are a very cost-effective drug. So there are a lot of people out there on them.
Correct.
And
they work.
Yeah,
They work very well.
And they work. Even though they're cheap, they work. And the main thing that people need to, the take-home message with diuretics is not only compliance, but compliance with the monitoring that goes on with these diuretics. Sodium and potassium, yes, that needs to be monitored. They can lower your sodium, they can raise your potassium. Some of them lower your potassium. Other things about diuretics that can be rather dangerous is seizures from hyponatremia or too low of a sodium.
Delirium as we know it. Yeah.
Altered mental status, very common, especially in the elderly population. We see more in-hospital admissions, I would say almost as much as chest pain today from altered mental status secondary to diuretics. Dehydration in the elderly lands them in the hospital almost every time. And it's scary. You over-diurese someone, they will be dehydrated.
Yeah.
It's plain and simple. So what are things that we can do at home to monitor our diuretic therapy? Everyone has a bathroom scale, or should. Sudden weight changes.
That's a very good point.
Sudden weight changes. You know, they can pick up the phone and say, "Doctor, I lost 5 pounds in a week." Well, I doubt that's from dieting.
Maybe there's an app for that
Yeah,
in the future.
you know.
An idea.
So again, that's the second danger is dehydration. The first being hyponatremia and fluctuations in potassium. The third danger of diuretics is volume loss, especially in the elderly. Volume loss can induce angina. It can exacerbate angina in the heart, which if your coronary arteries are already blocked, a diuretic can really complicate that as well.
Well, it's going to play with the potassium, and that's not a good thing either.
No,
for the heart rhythm, so, yeah.
no, you're gonna be at risk for arrhythmias, and when you're dehydrated, you also have to remember that your other drugs are going to build up a higher level because they're excreted by the kidney,
Well, that's true, yeah, they're gonna be in a higher concentration,
always.
yeah.
And
That's a
especially
good
your
point.
diabetics, your insulin controlling drugs will develop high levels, dropping your glucose really fast. And again, here you are back in the emergency room.
Exactly, yeah, for the diuretic. People with the gout,
Sure.
say Joe comes in, he's got the gout, he's got hypertension. Now, uric acid levels rise if you put somebody on a diuretic, hydrochlorothiazide. It has a potential to raise the uric acid. So, say this fellow has had the gout, a couple bouts of the gout. What would be your choice then?
Choice then, you would want to go to something like maybe ARBs or angiotensin inhibitors. I would also consider, in that case, beta blockers and alpha blockers in a case like that. Central acting agents such as clonidine.
The big drugs.
Yeah.
Clonidine's an old drug, but it works well. It's a cheap drug. But if you don't take it, rebound hypertension, you could be bad if you.
Yeah. I mean,
But yeah, there's a lot of choices that you can go to.
there's a lot of choices. It all
Good.
depends on the patient's medical profile.
What's the end result of someone that's hypertensive? How does it feel? I mean, what are the symptoms of high blood pressure for a patient? What do they tell you their symptoms are? What do you see a lot? What's the presentation that you see oftentimes in your clinic in high blood pressure patients? Sometimes I know they have no feeling whatsoever. I've been in a situation, I've taken somebody's blood pressure, it's 170 over 105, and they say, I feel fine. I look at them and say, really? Or 180, and it's almost emergent hypertension, but these people feel good. What is the symptom? What are the symptoms?
The symptoms of hypertension is when the patient will walk into your clinic or your office and present with, number one, headaches. Unexplained headaches, that I would say that's probably number one. Number two would be nausea. Number three, blurred vision. Number four, weakness. And then your catastrophic symptoms such as stroke and myocardial infarction or heart attack.
You laid into my next question,
Okay.
Eric, actually.
Sure.
My question being that, what's the damage? What is hypertension going to damage? What organs is it going to affect?
Okay.
In an adverse way?
If we don't control hypertension, the whole reason we're trying to control hypertension is to prevent morbidity and mortality. And let's talk about morbidity first. Stroke and heart attacks. Every day, in this, the emergency department sees probably 25% of its cases could be chest pain that day in any given facility, and it raises a big concern. But yeah, I would say myocardial infarction and the symptoms of that, of course, being chest pain, generalized weakness, syncopal episodes,
And you mentioned stroke as well.
and stroke.
Hemorrhagic stroke we talk about, and even occlusive stroke as a
Sure.
result of hypertension. But both
Yeah,
possible.
uncontrolled hypertension does lead to stroke, both ischemic and hemorrhagic strokes. It can lead to it. There are other factors that go with that, but absolutely. We're trying to basically control morbidity and mortality. It is why we're treating hypertension in the first place. We're not treating it,
That's why it's so important.
right, it's so important. We're not treating it for any other reason than that.
You mentioned one of the symptoms, blurred vision, damage to the retinal arteries. You want to talk about that, a potential effect of hypertension?
Very good question, Rick. Every primary care physician in his preventative medicine assessment should ask about yearly eye exams, especially in the hypertensive patient, the diabetic patient, patients that are at risk for macular degeneration and glaucoma, of course. But hypertension, uncontrolled hypertension definitely needs an eye exam. No question there. How often do you get an eye exam? That can vary depending on, again, your medical profile. I would say every 1 to 2 years is a great idea.
Can you do an adequate eye exam in your office, or does the patient need to go and see an ophthalmologist and get the eyes dilated so that with their slit lamp examination and the dilated pupils that they actually can do maybe a better job?
You can assess in the office personally, with the new equipment we have today, the ophthalmologists are a lot more prepared for that than, let's say, the primary care doctor. I generally work very close with a couple of ophthalmologists that regularly screen for hypertensive retinopathy and diabetic retinopathy, and I leave that to people who have the proper equipment in their office.
Yes, as you said. Malignant hypertension. I mentioned emergent hypertension. Malignant hypertension is the next step. When do you go to the emergency room with high blood pressure? With symptoms?
When do you
what
go?
reading? What reading might you have?
If you're having headaches, such blurred vision, or unexplained nausea, that should drive you towards the walk-in clinic or the emergency department. I would also add to the fact that you mentioned the malignant hypertension. That is a high systolic blood pressure, usually over 180 to anywhere from 180 to 220, 250 maybe. But that is where we call it malignant, because that is a medical emergency. You need to go to the emergency room fast. That is stroke range. That is heart attack range. That
end
is
organ damage. Name some of the end organ damages that occur as a result of this malignant hypertension.
renal failure, stroke, ischemic and hemorrhagic both, myocardial infarction or heart attack. Absolutely. Aortic aneurysm is also in there too. If you have an aneurysm and don't know it,
That can enhance it and augment that process, cause it to expand.
yeah,
probably.
hypertension will unmask your aneurysm at a very costly price.
And the people that bleed out in an aneurysm that ruptures from hypertension, the stats are not very good on survival of that type of condition.
No, they're extremely poor.
So the take-home message for the viewing audience would be: take your medication, stay on your blood pressure medication, do your lifestyle changes, but leave it to your doctor. Don't stop taking your blood pressure medication because you feel you're fine. You're fine because you're on the medication. It should be left to the professional when to come off of those kind of drugs.
Right, and when you're treating secondary hypertension, especially in the environment, in the emergency department, you have to really closely consider secondary causes you're going to get the blood pressure down with drugs, but secondary causes, there are a wide array of them. You do a lot of chiropractic work. Would you say people in generalized pain, especially severe lower back pain with disc herniation, do you see fluctuations in their blood pressure just from being in pain?
Oh, pain's a big motivator for drives blood pressure up very high.
Right.
Any type of pain does. Of course, back pain, neck pain,
Sure.
definitely will cause the blood pressure to go up.
That's one secondary cause, back pain. Medications taken for pain also can increase blood pressure.
Got a question about medication, remind me of, and I wanted to ask you to bring this out for the viewing audience. Non-steroidal anti-inflammatory agents taken with diuretics. The function of a non-steroidal is to block the production of a compound we call prostaglandins. Now, those are the pain mediators. The prostaglandin also, though, from our medical school training, it dilates the renal arteries. So the kidney is not a very smart organ in the body. When it's less blood supply, it thinks it's got volume depletion. So it rallies to hold on to that sodium, to pull that water back into because it thinks we've got to pump up the volume here. We've got to bring the volume of the intravascular volume back up because we're dehydrated, we're depleted. So do the blood pressure medication, it kind of like offsets the blood pressure medication to some extent.
It can raise the drug level actually of
The clearance of the drug.
Absolutely. You decrease the clearance of the drug level will build up. Yeah, that is without a doubt. Other secondary causes of hypertension. In an emergency environment, you may see that in street drugs. Some of these amphetamines and cocaine and
That causes hypertension too. A lot of these young kids
you get
taking
them off.
these energy drinks. Let's talk about these energy drinks that, a guy is perfectly healthy, doesn't have hypertension,
Right.
drinks one of these energy drinks, or a guy, does street drugs,
Sure.
Such as cocaine, and can cause an array of problems, can cause an MI, and somebody doesn't have any blockage from vascular spasm. But, you know, there are many things out there that can bring a person's blood pressure way up and in a normal, healthy vascular system. I wanted to bring that up about the non-steroidals because, yeah, for a number of reasons. I pointed out to the fact that as far as the volume, how it affects the kidney, for the kidney to rally in increasing its amount of sodium retention, but also it decreases the clearance of a drug as well. So it causes compound
Right.
problems, yeah, double problems.
Right.
I want to come back to, you know, we talked about, you know, the actual mechanism of hypertension, high blood pressure, the increase in volume in the heart, and then we talk about the vascular system. And coming to the vascular system, it's the smaller the lumen, or the smaller the opening in the blood vessel wall for the blood to go through, the more pressure you have. Pressure goes up. Lumen gets small, pressure will go up. And it's a matter of physics. So individuals are put on a diet called the DASH diet. It's a diet associated with stopping hypertension. That's why it's called DASH, D-A-S-H. That's what the DASH stands for. But it's a diet that is rich in magnesium. It's a diet rich in potassium. And those two compounds have the ability to lower blood pressure as well, from a natural and, I'm saying, lifestyle modification.
Sure.
But there's another component. You know, the endothelium, inner wall of the blood vessel is called the endothelium, and it produces a substance called nitric oxide. Mm-hmm. And as we get older, we lose that ability to nitric oxide. So I think you bring on those fruits and vegetables that are high in magnesium, high in potassium, that the body maybe is in need of, and plus these fruits and vegetables contain a great deal of components that increases the nitric oxide production. When you increase that level of nitric oxide, the blood vessel wall will relax, kind of minimizing the hypertension. This is nature's way of controlling blood pressure. But if people ate correctly, you know, that's one part of that DASH diet, by eating fruits and vegetables and low dairy fat products, over an 8-week period, there has been recorded low blood pressure has come down, not low, but has come lower, been able to lower it through the dietary intervention of the DASH diet. But that's a component on that particular diet. And you mentioned that we always try to get somebody to change their way of lifestyle. And, you know, I've heard it say that it's easier to change somebody's religion than change their lifestyle. And it's so true, you know, where we live here in South Louisiana, and the foods we enjoy and our culture. But I think moderation, you mentioned moderation is the key for people. We mentioned weight loss. We mentioned salt reduction. Could you do a brief recap to the viewing audience of how to prevent getting hypertensive? If they are hypertensive, what measures that they can take control of? We want to empower them with knowledge. We want to give them a little information to take home that they can improve their health with. And so give us some tips here.
Well, if you have a family predisposition of hypertension, protect yourself in these ways. Weight loss, maintain an ideal body weight. A body mass index of less than 25 is ideal. That's one thing you can do. Avoid excess alcohol. Alcohol is one of the most common causes of hypertension. Never forget that. Also, eat healthy. 2 gram sodium diet, average 2 grams per meal a day. Avoid processed foods. Stick to more natural foods.
Yeah, we didn't talk about exercise, but that's a component too of this.
Exercise is a very, very good component to control blood pressure, and people just don't do enough of it today. Americans tend to spend more time trying to find other ways to lose weight than using what's in front of us. Exercise and diet, if you do them, they will work.
We all know there's no quick fix for losing weight. You actually have to cut back in your diet. And I've seen people many times will try to exercise without actually cutting back in their diet, thinking that, you know, I'm exercising now, I really don't have to watch my diet. But they really do. I mean, diet is the essence of where the weight loss program is going to occur. You just can't out-exercise the calories. And I tell people that all the time. They ask me, you know, that advice, I'm trying to lose weight, and they start working out, and they say, well, you know, I've been working out for 3 months now and I haven't lost any weight. And then I said, well, you know, did you keep a diet journal? You know, and what's your caloric intake daily? What's your sodium intake? And maybe they're on blood pressure medications as well. But, really have to cut back in the calories. You really have to eat better, as we mentioned, the type of foods, the fruits and vegetables, and
Right.
those type of healthy eating. And as you mentioned, keep sodium below 2 grams a day.
Yeah, weight loss does involve combination therapy.
Goes hand in hand with the exercise, the weight loss, and
It
the,
sure
the
does.
salt reduction.
Exercise is a very good adjunct, so to speak, for calorie or lowering calorie intake. If you lower your caloric intake combined with combined with exercise, you're going to lose weight. If you create that calorie deficit, you're going to lose weight. Exercise helps you increase your calorie expenditure and helps therefore create a calorie deficit. Now, if you're eating more than 1,800 calories a day, even with exercise, you're going to stay in more of the neutral ground. You're not going to gain or you're not going to lose. And that's the most common complaint that I hear from patients about exercise and weight loss. Doctor, I'm just not losing weight. I've tried the diet and exercise. The diet journal, you go back to it, there's the answer.
I've seen it myself.
Exercise journal, I exercise. What do? I run on the treadmill. How many calories a day are you burning? Oh, I'm burning 40 to 50. Well, that's more of, that's just enough calories to loosen up the joints. That is not enough calories to burn adipose tissue or fat.
I agree with you. With the iPhone, I have to take that point. With the iPhone, there's an app called MyFitnessPal.
Okay.
I'm very familiar with it. I've advised people to use MyFitnessPal.
Okay.
It does your caloric intake daily. You can look up the foods and the proportions of each food content, and it gives you a nutritional rundown of what's in it. Also tells you how many calories, how many carb grams, how many fat, and how much protein grams. So you get a pretty much rundown nutritionally on everything you're taking in your diet. And also, another part of this MyFitnessPal type app, and I'm not doing an ad for it, but it's an adjunctive, it's a tool that a patient can use. You plug in how much exercise you do, and it tells you how many calories you have negative at the end of the day. And it's all about getting that negative balance of calories that you've taken in versus how much you've burned up. You want to be burning more than you're taking in to actually have weight reduction to take place.
Right.
But I think it's a good point. We just, people need to be disciplined, and we'll act as, but we're all talking here in this discussion about high blood pressure. We're talking about the patient, and we're motivating the patient to take an active role. As a physician, you can only do so much. A doctor can only do so much in the treatment of the patient. If the patient's non-compliant, if they don't take the medication, if they don't choose to eat right, lower the sodium, you really can't be, they really can't achieve their goals by just, leaving it up to the doctor. It's more than your responsibility. It's their responsibility, and we want them to take serious responsibility for their health, and put this knowledge together, this information that they're gaining today about high blood pressure, and actually incorporate this into your lifestyle. Make these, it's hard to change. You can't exercise, go on a diet, stop salt, and get rid of all your great things at one time. Take one thing at a time, I think, if they can cut back in the salt first.
Sure.
When they get that under control, then they can do other things. But if you set yourself up to stop everything at one time, I think you set yourself up for failure in your lifestyle change. But we need to work on ourselves just one point at a time. And in the case of the hypertension, high blood pressure, weight reduction, the caloric intake kind of thing, the exercise can go together, and then they can start watching their diet a little bit. And because the MyPal fitness app does tell you how much sodium you're taking in. So at the end of the day, you say, look, my sodium is here, and then they take their blood pressure. And their blood pressure is up because they're taking like 12 grams of sodium. And if you eat one thing, it can give you like 8 grams of sodium, and it can be a stick of like something like beef jerky. You don't realize it. People don't read the packaging, and it contains like maybe 9 grams of sodium. So right there, they've gotten 2-3 days of sodium intake in one meal, and they're still going to have the rest of the week to eat and take in more sodium. So the sodium overload thing is really something that really we need to be cognizant of.
Absolutely, and with the ever convenience of fast food around, one single fast food meal or fast food combo meal, as they call them, can give you enough of a sodium intake to last you 3 days.
And fat as well, fat intake as
Oh,
well.
absolutely,
I'm-
yeah.
I'm-
That's probably the worst thing, health-wise, that one can indulge on a daily basis. It's fine, you know, once or twice a month or so, but, as you get older, your body's gonna tolerate that a lot less, you know, and, you don't have that metabolic rate that you had, you know, when you were 17 and 18, you know, if you're 35 on up, you're not going to have that. And people need
Right.
to realize that they have less ability metabolically. They're metabolically challenged after the age of 35.
But you just can't have that mugged into hamburgers and fries and still look great. You know, if you're 35, 40, 45, that you did when you were 18. You can't go
Well,
out and eat
right.
like that and still look good.
If
In other words.
if you're an adult, you have to act like it, and you have to eat like it. And you know, kids can eat that stuff all day and stay the same weight, no problem. You know, but you know, the general population of adults, we just don't have that anymore, and we have to accept it. And if compliance is everything, compliance with diet, compliance with medications are everything. If you're compliant, expect results. But if you're not compliant, do not expect results.
Exactly, correct.
It's that simple.
Exactly. I think we've given the viewing audience a lot of information here tonight. I think we've given them a lot to think about in managing their blood pressure. If they think they have blood pressure, they should see their family physician, they should see their doctor. You know, if they have any questions, of course, they can contact us through the email address shown on the screen, or also call. I think there's a telephone number as well shown.
Okay.
Any questions, if they have any questions for Dr. Fontenot, please feel free to contact him about the programming, or if you have a question about anything, you can contact either one of us, or answer any questions you might have about the show, or any comments about the show. We'd appreciate them. I want to thank Dr. Eric Fontenot here for being my guest on this show tonight. Dr. Fontenot practices here in Lafayette, Louisiana. He practices in the All Center across from Lafayette General. He's an internal medicine physician here in Lafayette. I'm Dr. Rick Duplantis, wishing you best of health, and after all, be responsible. It's your health. Have a pleasant evening. God bless.
Thank you.
We just, they would have cut it, I guess, at this point. But anyway, I'll put in the credits. How did we do? What time were we at? Here.
Perfect. Yes.